சரிங்கக்கா. சரிங்கக்கா, ஓகே, நான் கேட்டு சொல்றேன்.
Welcome, ma'am. Welcome, all of you. Good morning, ma'am. Sorry, audio irukka illaya?
Good morning, madam.
Kekudha, madam. Okay, madam. இன்னொரு 2 minutes, madam.
Single da.
நான் சும்மா தான் போறேன்.
Okay, madam.
பாத்துட்டு இருக்கு.
எந்த ரிமோட்?
என்ன டாபிக்?
Ma'am, Sita Lakshmi, ma'am. Hello, madam.
Yes.
Ma'am, the first case you want to present the second case?
Yeah, second case is okay for me.
Okay, madam. Okay, fine.
Second case start பண்ணல.
Interpreting his Is it live? It won't be available, recorded available.
In the college, PG.
Ask ma'am to put your name in.
Good afternoon to you all. Welcoming you all to the 29th City Pathology Meet. And Chandra, madam, are you there? Ma'am, can we go on without much delay? Can we go on with the first presentation? If SRMC is ready, Dr. Priyadarshini?
Yes, ma'am, I'm ready, ma'am.
Okay, ma'am. Then you can share your screen, ma, Dr. Priyadarshini.
Yes, ma'am. Ma'am, it says sharing host disabled participants screen sharing.
Okay, ma, just wait.
Okay, ma'am.
Ma'am, now you can share your screen, ma'am. Enabled, ma'am.
Sarangan, can you check?
Yes, ma'am, you can share, ma'am. Dr. Priya.
Dr. Priya, parunga Priya. Dr. Priyadarshini, I think your screen is visible. You can start.
Okay, ma'am.
Slide share, you put it on slide share and you can start.
Yeah. You can hear me also, no, ma'am?
Yeah, you're very audible and you're very clear.
Yes. Thank you, ma'am. So, good afternoon, everyone. I'm very happy and thankful for giving me this opportunity to present a
Excuse
very
me, Dr.
interesting.
Priya, slide share la podunga. Slide share.
It's in slide share, ma'am. Can you, are my slides changing?
Yeah, ma, yeah. Okay, ma. You can continue.
Yes, ma'am. So good afternoon, everyone. Thank the organizing and committee and our HOD for giving me this opportunity. I would like to present an interesting case we came across in our department. So it's a 34-year male who presented with swelling in the left side of the neck for a duration of 5 months. It was
Excuse me, Priyadharshini, can't you put it in slideshow?
Ma'am, it's
Slideshow mode.
in slideshow only,
There
ma'am.
is a slideshow mode, no?
Ma'am, it's in slideshow for me. Are you not able to see, ma'am?
No, only the small slides are there, not the big screen. Madam, is there any problem?
இல்ல மேடம் இங்க ஒண்ணும் பிரச்சனை இல்ல, not on our side.
So for her, there
Yeah,
is no
just come out and go in again. Just check if it is possible.
Sure,
Just
ma'am.
share again. Just see if it is possible to share again.
Dr. Priya, அந்த slide show tabல போய் பண்ணுங்க. Slide show tabல போய் பண்ணுங்க.
Sure, ma'am.
டாப்ல slide show அது இது பண்ணுங்க. அத கிளிக் பண்ணுங்க slide show.
1 second, ma'am. Just give me some time.
டாப்ல slide show இருக்கு. You just have to click it.
Okay.
Yeah, you got it, ma. You got it. Thank you.
Now is it okay, ma'am?
No, ma. அந்த அனிமேஷன்ஸ் பக்கத்துல இருக்க ஸ்லைட் ஷோ நீங்க கிளிக் பண்ணனும். அப்படி ட்ரை பண்ணி பாருங்க. அனிமேஷன்ஸ் பக்கத்துல இருக்க
Ma'am, you are telling in the PowerPoint itself.
ஆமா.
Okay, ma'am.
அனிமேஷன்ஸ் பக்கத்துல இருக்க ஸ்லைட் ஷோ நீங்க கிளிக் பண்ணனும்.
Okay, ma'am. Just doing that.
From beginning in போடுங்க. From beginning.
Yeah.
Or from current slide, whatever.
Yes. You see now, ma'am? I'll start with that only.
Wait, it's coming. We have to wait to see.
Okay.
There's something wrong, I think. Huh? Varlama, it doesn't come. Maximize zoom பண்ணுங்க right hand side corner ல.
1 second, ma'am. Actually, for me, it is moving and the slideshow is opened. Let me check it once more.
If she's not able to do it,
Suggest something?
okay.
Dr.
Okay,
Priyadarshini,
ma'am. அந்த நீங்க ரைட் ஹேண்ட் சைடு கார்னர்ல அந்த ஜூம் கிளிக் பண்ணீங்கன்னா இன்னும் கொஞ்சம் ஸ்லைட் ஜூம் ஆகும்.
பரவாயில்ல,
64% அந்த மாதிரி நீங்க பண்ணலாம். ரைட் ஹேண்ட் சைடு கார்னர் ரைட் லோவர் டவுன்.
It's in 64% right now for me, ma'am. And
இன்னும் கொஞ்சம் இன்க்ரீஸ் பண்ணுங்க.
Okay. I put up to 95.
Yeah. This is better.
Is this better, ma'am?
This is better.
Are the slides changing now?
You start now.
Okay, ma'am. So it's a history of a patient. He's a 34-year male who presented with swelling in the left side of the neck for a duration of 5 months. The swelling was insidious in onset and gradually.
The slide is not moving. Okay. Have you gone to the next slide?
No, ma'am, I'm in the same slide only.
The city pathology meet slide.
No, ma'am, I've gone to the next slide now.
That's not the slide now.
Slide
Are
is
you all
not
able to
moving
see?
now.
It's not
Dr.
moving.
Priyadarshini, Dr.
Yeah, ma'am.
Priyadarshini,
Yes, ma'am. I'll
stop
just
sharing and share again. It will be all right.
Yeah, just stop sharing and do it again, Priya.
Yes.
Because slides are not moving.
Can you see now, ma'am?
Yeah, just go back, go to the next slide. Let's see if it's moving.
I'm changing the slides. Are they changing, ma'am?
No,
No.
no, they're not changing. Priya, it's not changing.
One second.
Yeah, it's changing, ma.
Now it's changing. Head with this, yes.
Is it fine now, ma'am?
Yeah, it's fine.
Okay,
Go on, Priya.
fine, ma'am. So this is the first slide, and now I'm showing the clinical history slide. And the next is the examination slide. Were you able to see all the 3 slides now, ma'am?
We are able to see only the first slide, the clinical history slide. Only, I think if you move and then it'll come to the next slide.
Okay, ma'am, I'll just proceed. If any issues, then I'll have to look into it, ma'am. So here the patient presented with a swelling, and it was gradually increased and reached this site, and he developed ptosis on his left eye. So past history, there was no comorbidities and there was no significant family history. He had normal bowel and bladder habits. On examination, the patient was not pallor, icterus, cyanos, or clubbing. Other no lymphadenopathy or pedal edema. CVS, RS, and abdomen were unremarkable. On central nervous system, there was Horner syndrome on the left side with ptosis, meiosis, and anhidrosis. So local examination of this one.
Your slide is not moving, ma. Doctor.
Okay, ma'am. Then I think let the next person present, ma'am. Meantime, I'll just check this. Is that fine, ma'am?
Okay, ma. Is Dr. Bharati ready?
Ma'am, yes, ma'am.
Yeah, then
Shall
you
I
can
start
start, Dr. Bharati.
sharing, ma'am?
Yeah, yes.
Ma'am, again, as Priya got the message saying host to disable the participant screen sharing, it's showing, ma'am.
Dr. Sarangan. Dr. Sarangan.
Balan,
Yes, ma'am.
you add all the participants as a host. Default.
Yes, ma'am. It's not under mine. I'm not doing it. And Dr. Sarangan is doing it.
She's sleeping. She is not awake at all. Post lunch sleep.
Madam. We'll check. Just give me a second, madam.
Yeah.
Dr. Sarangan, அவங்கள ஹோஸ்ட் நீங்க ஷேர் பண்ணணும். நீங்க அவங்களுக்கு டாக்டர் பாரதி உங்களுக்கு ஹோஸ்டா தான் இருக்கீங்களாமே?
Ma'am, it's still showing the same. Host disabled participant screen sharing. When I click the start sharing screen, it is showing me that it's not allowing me to share.
இது என்னடா என்ன சொல்ற?
இல்ல பிரசன்டேஷனை ஷேர் பண்ணி விட்டீங்களா? நான் வேணா என் லேப்டாப்ல இருந்து ஷேர் பண்ணி பார்க்கவான்னு கேக்குறேன்.
இத ட்ரை பண்றேன். ஒர்க் ஆகாட்டி நான் உனக்கு பண்றேன்.
ஓகே. சரி.
சரிடா. நான் பின்னாடி வேற ஏதோ 2-3 இது ஓபன் ஆயிருந்தது எல்லாத்தையும் இப்ப க்ளோஸ் பண்ணியிருக்கிறேன். அதுக்கப்புறம் ஒர்க் பண்ணதான்னு பார்க்கலாம்.
Balan, your WhatsApp messages are being shown. Please close this.
Now Priya's screen is visible.
Okay. Is it
Priya,
changed?
you can start.
Priya, your screen is visible. Priya, you can go ahead. Ma'am, can she
Yeah,
start?
she can go ahead, please.
Okay, ma'am. I'll just check if slides are changing.
You just move, Priya. First slide is absolutely fine. Yeah, it's moving now. Yeah.
Yeah,
Fine.
first slide, history you've said.
Yes, ma'am. Next is examination. Can you see them now?
Yeah.
Yes.
So I have we already discussed the history. So we presented that the Horner syndrome and swelling in the left side of the neck. On local examination, it was a mass of 5 by 5 centimeters in the left side. Upper limit was indistinct and lower border it was up to the hyoid bone. It did not move with deglutition and mobility was restricted. It was a non-tender and left carotid artery was displaced anteriorly. Radiology showed a mass to be attached or arising from the left sympathetic nerve plexus. So this we received a core biopsy for a second opinion for this mass. So the first striking point we saw in the slide was it was filled with melanin pigment. It was a melanotic lesion, and higher power we could see some spindle to epithelioid cells with vesicular nuclei. Some of them showing, most of them showing micro to macro nucleoli, and there were loads of melanin pigment in the cytoplasm. So mitosis was around 1 to 10 in 1 by 10 hyperfields, and necrosis was around 30%. The immunohistochemistry was done outside, which was positive for melanase, SOX10, and S100. So with this clinical history and presentation, we had two differential diagnoses in us, like malignant melanotic nerve sheath tumor and a malignant melanoma. There was no previous skin lesions, and radiology-wise, the mass was seen to be arising in the nerve plexus. So we favored a diagnosis of malignant melanotic nerve sheath tumor and advised BRAF mutation analysis to rule out the melanoma. Following this, the surgeon decided to excise the mass, and this is the gross we received. It was the striking is a dark tar-like black mass, homogeneous, solid, and was measuring around 5 by 4 centimeters. So this is a microscopy, whole mount view. And as we saw in the core biopsy, the very similar cells, the cells fully laden with melanotic pigments, spindle to epithelioid cells. You can see the cytoplasm with granular melanin pigments. And in some areas where the pigmentation was less, we could see the nuclear morphology to a certain extent. You can see all the cells had vesicular nuclei and nucleoli with granular pigmentation in the cytoplasm. So there were almost 24 nodes excised, and the 7 nodes showed infiltration by the tumor. This is a section of the lymph node with the tumor deposit. So thus we have 7 nodes involved, and summarizing the points, we have a melanotic lesion with lymph node involvement, positivity for melanocytic markers, and Ki67 index is 1%. So with the molecular workup, we did a BRAF mutation analysis, which turned out to be negative. So hence malignant melanoma was ruled out, and we favored the diagnosis of melanotic schwannoma or melanotic MPNST. So this tumor is usually associated with the Carney complex. So we did a Carney complex gene analysis for the PRKRA1A gene. However, the gene analysis showed no pathogenic variant identified. So a final impression, it's a case of malignant melanotic nerve sheath tumor, probably a sporadic variant. So coming to the discussion, a few words on malignant melanotic nerve sheath tumor. It is a rare nerve sheath tumor, also called as malignant melanotic schwannomas. It is composed of Schwann cells arranged showing melanocytic differentiation. It usually has a very aggressive clinical behavior. The average age of presentation is around 33 years. However, if associated with the Cornet's complex, it occurs a little earlier, around 23 years. Location arises from the spinal or the autonomic nerve near the midline, or can arise from the nerves, autonomic nerves in the visceral organs like GIT, bones, soft tissues, heart, bronchus, or liver, skin. Clinical features is based mostly on the presentation of the site of the mass with pain or sensory abnormalities, or it can be with the mass effect. So as we discussed, it can be associated with Carnet's complex, which is autosomal dominant syndrome with 50% PRKRA1A inactivation. So we know Carnet's complex is associated with myxomas or myxoid lesions, 40 skin pigmentation, and endocrine overactivity. Hence, when we identify this tumor, it is essential to rule out Carnet's complex because the occurrence of the other lesions can be very frequent in the Carnet's complex, or it can be sporadic as it was in our case. Grossly, it is usually a solitary mass, except when it is associated with the complex. It can present with multiple and multicentric tumors. It is if you see in the gross picture, this is a picture from our WHO Blue Book. You can see it is a very circumscribed mass and solid, and it has classically described as a black tar appearance, like the tar, TAR tar. So they have given an essential desirable diagnostic criteria for this lesion. These are frequent origin from the paraspinal or the visceral autonomic nerves, and microscopy you're going to see fascicular to sheet-like proliferation of heavily pigmented uniform plump spindle cells, and co-expression of the melanocytic markers as well as the neural markers like SNRET, SOXN, HMB45, and melanine. And there can be a loss of PRKRA1A expression. So another features, we can have samoma body is in the microscopy, but there is no clinical difference or presentation if there is a presence of the sammomatous bodies. And when do you call it as a call for malignancy? There is no strict criteria. However, when you see a large vesicular nuclei with a macronucleoli, brisk mitotic activity, or a necrosis, you think of a malignancy. So this is a picture where you can see the plump to spindle cells with some of showing nucleoli and the melanin pigmentation. And here you can see sammomatous bodies also. So the prognosis is it's difficult to predict because even when the microscopically they can have a very subtle look, they can metastasize in the future, and it has an aggressive behavior, and the local recurrence and the metastatic risk is assessed to be 26 to 45%. Hence, these patients require a long-term follow-up. So just a word on this BRAF600V mutation. It is a serine threonine kinase, part of the MAPK signaling pathway. So this mutation analysis plays an important role in this case to differentiate between the melanoma because the treatment and the prognosis is going to be entirely different in case of melanoma and the melanotic schwannoma. So some of the BRAF600E mutations positive tumors. And these are my references. Thank you. Any questions?
Very nice.
LG னா என்னங்க?
என்ன மேம்?
இதுல LG போடுறாங்கல அதுனா என்ன?
LG யா மேம்?
கிளாஸ்ல லார்ஜ் குரூப்பா?
லார்ஜ் குரூப்பா இருக்கும் நினைக்கிறேன் மேம்.
Nice presentation. Only one thing which I wanted to say was, see,
yes,
melanotic schwannoma, the terminology is still retained or has it been changed into malignant?
Chandra, your voice is...
Ma'am, in WHO book, it has given as an equivalent name or alternative name as melanotic schwannoma, ma'am. The topic it is given as malignant melanotic peripheral nerve sheath tumor. However, the other names, it is still given as melanotic schwannomas as mentioned.
Chandra, melanotic schwannoma has been in the history or in the pathology this thing for so many years now. This we have also seen in GH. And rough incidence of this tumor, overall incidence of this tumor, any idea?
Ma'am, incidence, this is a very rare tumor. They say among the nerve sheath tumors, is more common only in 30 to 40% of Carney's syndrome patients. You can see this tumor. As a sporadic case, it has been a very rare incidence only. So if we see in this 2014 article, there were a study of 40 cases over a period of 10 years. And this is again another study in 2005. They have mentioned 13 cases again over a period of 5 to 10 years, ma'am.
Madam, earlier it was thought to be a benign tumor. That's why the benign name, melanotic schwannoma.
Yes.
Now it is confirmed, confirmed that it has a malignant behavior. And now if you look back, maybe there are, as you said, the incidence, as Priya very rightly said, it's less, but we have to now consider them as malignant and the behavior might be much more aggressive.
Yes, even though it is
even though the synonymous name is melanotic schwannoma, now that it has been seen that it has an aggressive behavior. I mean, it has a malignant potential.
Sandhya, don't be surprised next year if they may give some other name to it.
Yes, quite possible, ma'am, quite possible.
Practicing persons, we find difficulty only mostly in differentiating in a melanoma and a MPNSC. So in that case, probably the mutation study helps us to differentiate.
No, but site is also important. No, you don't get a melanoma in the neck that will attach to your nerve plexus, right? So that would have definitely helped us.
Yes, on the
to
clinical.
arrive at the diagnosis.
Yes, the clinical, yes, exactly, the location arising from them. Yes, very important. Yes, madam. Yes, yes. Yes, all these classifications are made in a beautiful place called Lyon, madam, in France. I think that's why all the names and the classification keeps happening often. All the experts meet there, and I think that's why we keep getting new names, because this is an aggressive tumor. Yeah. Thank you, Priya. That was nice.
Thank you.
Thank you, Sita,
Thank you,
ma'am.
Dr. Priya. That was a nice case. Can we go on to the next case, Dr. Bharat? Madam Sita, madam, would you like to present, madam?
Madam?
Sita Lakshmi, madam, can you share your screen?
Dr. Lydia from Velapan Chowdhury will be presenting the first case, and that will be followed by our case from Chandra.
Okay, madam. Dr. Lydia, welcome, and please share your screen.
Valan, you have to enable us.
Yes, ma'am. Yeah, just a second.
Yeah. Slideshow.
Yeah, Dr. Lydia, your screen is visible.
Yeah.
Full screen, please. Yeah. Perfect.
Good afternoon. We will be presenting a case of a 10-month-old baby who was antenatally diagnosed to have a renal anomaly with hydronephrosis. And they suspected left multicystic renal dysplasia with pelvic junction obstruction and thickening with twin parenchyma and well-formed left artery. Right kidney was found to be normal. So we received left kidney with ureter. The gross was brownish cystic mass measuring 5 × 3 centimeter. Cut surface showed multiple cystic spaces with hemorrhagic surface. Ureter was dilated and no normal renal tissue was seen. This is the gross which we received, wherein you couldn't identify any normal renal parenchyma, only multiple cystic spaces were seen. On microscopy, we could see multiple dilated cystic tubular spaces. And on a higher power, we could see multiple dilated tubules as well as cystic spaces. Which were lined by cuboidal to flattened epithelium. Areas of thyroidization could also be seen. Here you could see lymphoid, well-formed lymphoid aggregates forming follicles, and interspersed you can see glomeruli. Few of the glomeruli are aborted, whereas few are looking normal. They are interspersed among these dilated tubules. So higher power, again we could see these are normal glomeruli, whereas many abortive glomeruli were also seen in these legs. And the surrounding myxoid mesenchyme was seen, and here we could see the ureter, and there is marked muscular hypertrophy around the ureter. With all these findings, we gave a diagnosis of cystic renal dysplasia, possibly segmental, with uretropelvic obstruction. We thought we'll present this case because pediatric cystic renal tumors we don't encounter often. So a little bit about the embryogenesis of kidney. The urinary system starts developing by week 4, and by 10 weeks there is a good developed urinary system. Like you have the urogenital sinus from which bladder and urethra develops. From the urogenital bridge, the nephrogenic cord comes, and from the ureteric bud, the collecting system comes. The metanephric mesoderm, from that you have the nephrons developing. So the development happens in 3 phases: pronephros, mesonephros, and metanephros. And finally, we have the well-formed kidneys. So the classification of the cystic diseases, we have the Potter's classification. So the Potter type 1 is pediatric infantile polycystic kidney disease, and the adult would come under Porter type 3. This renal cystic dysplasia comes under Porter type 2. And Porter type 4 is cystic disease with intrauterine urethral obstruction. And we have few more renal diseases like the common renal cyst. So this is just a pictorial representation of the various cysts which can happen in the kidney. So few pictures. This is the autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney, RS multicystic dysplastic kidney, and then we also have simple renal cysts which are nothing but very thin line cysts, but size is also very small compared to other cysts. And we have the medullary sponge kidney, wherein the cysts are usually located in the medullary region as well as the pelvis, and the size of the cysts are also smaller. So the major differential diagnosis would be with the polycystic kidney disease. The polycystic kidney disease is usually bilateral and also associated with genetic links, and other organs are also usually involved in case of polycystic kidney disease. So few words about renal cystic disease. Usually it is unilateral. Bilateral forms are not compatible with life, and there are two theories about its etiology. One is the obstructive hydronephrosis leading on to dysplastic kidney, and the other would be the abnormal interaction between the ureteric bud and the metanephric blastema, causing a failure of differentiation. Usually it's diagnosed in utero or an early neonatal period. So this is the simplified schematic pathogenesis of the cyst. So urinary tract obstruction leading on to failure of the ureteric bud to integrate, leading on to abnormal metanephric mesenchymal differentiation, leading on to multicystic dysplastic kidney. So usually they're associated with uretropelvic obstruction, and they can also be associated with few symptoms. Usually it is a non-functioning kidney and has an appearance of bunch of grapes. It's important to have a serial monitoring of these cysts by ultrasound, because certain times it can involute as well. But after surgical resection, for unilateral cysts, there is a very good prognosis. Thank you.
Just to sum up, any doubt or any questions? Any doubt or any questions? You were able to hear me?
Yeah, yes, ma'am. We are able to hear you.
Now, this child actually presented to the nephrology department, and they found that the child actually it was antenatally detected, and they waited for the delivery to occur, and then they operated the child only around almost 1 year of age, 10 months. And since they found the right kidney was normal, only a nephrectomy of the left kidney was done, and this was the findings. Of course, for the sake of the postgraduates, normally we find the two important points for you to say it is a multicystic dysplastic kidney is, dysplasia, because, there is a loss of orientation. See, normally we find the glomeruli are situated in the cortex and the medulla will have the tubules. But here, this kind of a spatial relationship is totally lost here. You find glomeruli which are abutting the tubules. So that is one thing. And then abortive glomeruli are also there which are not developed. There are no capillaries within the glomerular tuft. And then embryonal elements will be there invariably. You will find a mature cartilage. But we didn't find any of the cartilaginous tissue in this multiple sections. We found only a mesenchymal myxoid type of a lesion. We called it segmental dysplasia because some of the glomeruli were well developed. So probably it is only the portion of the kidney which was affected in the process. And that is why we called it multicystic dysplasia, but possibly segmental. And the child is doing well after the surgery. The other kidney was normal. So, and the occurrence is quite rare. It's not that we come across this. In fact, Lydia was telling me that was a very question. So I don't know whether how many of them have actually seen multicystic renal dysplasia and these kind of lesions. It is not a very common recurrence. So I thought definitely we should include one of the non-neoplastic lesions of this kind of a renal anomaly, which is nowadays radiology helps a lot in arriving at a diagnosis, and this was antenatally detected, and they were closely monitoring the child, and they were able to do the surgery, and the child is doing quite well. So we thought we will definitely share this with all of you.
Madam, that was a beautiful case. And as you said, we do not see it, we do not have so much of pediatric pathology in many of the institutions.
Yeah.
And that's a very good eye-opener for everybody, madam. Thank you, madam. Thank you for sharing that case.
We go on to the next one?
Yes, ma'am, please.
Slideshow. Actually, Ipurna should have presented this case and I am proxy. Okay. And this was a 54-year-old female who, with a history of a slip and fall from a bike. I was really surprised that a 54-year-old female is able to run a scooter or a bike. And this happened somewhere time in 20. So during the COVID period. And because she had a fall and head injury was there, she underwent an MRI. And later they found that she developed certain symptoms like history of continuous watering of the eye in both eyes, and therefore the repeat MRI was done almost a year later. And this is the MRI finding. And can any one of the audience tell me where exactly is this is the lesion which you can see. Now, where exactly is the site? Can anybody guess the site and tell me, or can you send the answer in the chat box? Give me 2 minutes. Anybody? No answer. Okay.
Is it near the pituitary, ma'am?
Okay, that's one of the options. Okay. Now here, actually, I'll give you a small clue. Now this is the corpus callosum, right? You can see the corpus callosum, and that is a lesion. Now, that gives you any brainwave? Okay. Let us go back to the histology. This was fairly well encapsulated. Actually, grossly, it was a very big lesion. It was really very big. And I didn't tell you the MRI diagnosis was meningioma. Meningioma was a diagnosis, and actually it looked a very encapsulated solid lesion. It was about 4 to 3 centimeters, almost 5 centimeters in size. And you can see the capsule here, and that is the histology where you find lobules of tumor which are separated by vascularized thin septate, right? And that is the other area in which also you find almost an organoid pattern. You find these cells are lobulated and almost mimic an endocrine type of lesion with the vascularized septate which are separating these lobules. Now this is the other area in which you have almost like a schwannoma pattern. You see the palisading and spindle-shaped cells, and some of them looking like ganglion cells. So some neurofilaments are also there. And this is the other area showing you almost the same kind of a picture. And again a neural component. And here you find something like a boxing effect. See, some of them look like a glial cells mimicking an oligodendroglioma. And then that is the high-power view of this. See, almost like a oligodendroglial cells you find. And some of them are ganglion cells. So, you know, it was a very, very weird picture. And so that was actually a pineal gland. So we went ahead and researched the literature. And just to recapitulate the anatomy of the pineal gland for the sake of everybody, because you know I also forgot where the pineal gland was situated. I had to go into the books to see where it is situated. It's a very small endocrine gland just beneath the corpus callosum. That is why I asked you whether the corpus callosum, if you can identify the pineal gland. And surprisingly, it is also known as a third eye, just like Lord Shiva. Now, what is a third eye function? You see, we are able to distinguish between the day and the night only because of the pineal gland. So actually, if the pineal gland function is not there, we won't know the difference between day and night, just like what happens when we go abroad and come back. We all have jet lag. We sleep during the day and we are awake during the night. Now, that is because of this pineal gland may be not able to sense the difference between the light and the dark. So that is one. Second thing is it secretes melatonin and serotonin. And it also is a very important role in fertility and the menstrual cycle. And the early symptoms of the tumor are seizure, memory disruption, headache, nausea, etc. But this lady probably retrospectively thinking that she fell down from the scooter, maybe because she had a momentary small seizure or a memory disturbance. We do not know. She is not able to recall that. So that could be the retrospective. And this is just a normal anatomy of the corpus callosum. And look at the small nature of the the pineal gland, but that is actually an enlarged person. But the tumor was almost twice the size of this. Now, when you talk about the tumors, why we presented this case is it is less than 1% of all the CNS tumors. So we are very happy that we were able to get a tumor which is so rare in the global incidence, and that too the type of the tumor which I am going to describe is much more less common than any of the common pineal gland tumors. The most common tumors are germ cell tumors, which are also called as germinoma, which we have reported in GH earlier when we were all doing the neuropathology postings. And the other pineal tumors are mainly pineocytoma and a pineoblastoma, which both, I think, if you remember, I have already discussed pineocytoma and a pineoblastoma in the earlier city pathology meet. But then they can also have tumors which are arising from the neighboring organs. As a pressure effect, the patient can present mimicking a pineal gland tumor, which are all the other tumors which I have mentioned here. Now, WHO recently has introduced 2 additions to this pineocytoma and a pineoblastoma. The 2 additions are papillary pineal gland tumor and a papillary tumor of intermediate differentiation. Now, these are all the differences between the pineal parenchymal tumors and papillary tumors and germ cell tumors, which is all given in the textbook. So I'm not going into the detail. I'm just recapitulating the histology of the various pineal gland tumors. Now, this is a pineocytoma. Very, very characteristically, you find these kind of rosettes and increased vascularity and ganglion-like cells. You see that? That is the clinching point there. And this is a blastoma. Naturally, you will find embryonal type of cells. So these are all the embryonal type of cells, in addition to the rosettes that you find here. Now, this is the papillary tumor. You can see the papillary projections. So this is a pineal gland tumor of the papillary type. Now, our case did not fit in with any of these. As you can recall, whatever I have shown you there, it had a varied divergent morphology of neurofilaments, oligodendroglioma-like cells, then schwannoma-like areas, then diffuse sheets, where globular architecture with an endocrine pattern and a vascular septae separating them. So we made a diagnosis, but then we have to convince the clinician unless we do a IHC. So we had to go for IHC. Now this is under central neurocytoma. That's for a completion sake. We did an IHC marker. Of course, we don't have all the markers, so we had to resort to one of our the units in Hyderabad, which is the American Association, and that clinched the diagnosis. S100 was positive, synaptophysin was positive, CD56 was positive, and homogranulin was positive. So the final diagnosis was pineal parenchymal tumor of intermediate differentiation. Now, this is something like the Trisangal in between the pineocytoma and the pineoblastoma. So, a tumor of the pineal gland that is intermediate in malignancy between pineocytoma and pineoblastoma, and is composed of diffuse sheets of large organs of monomorphic cells which appear more differentiated than what we see in a blastoma. Now, this is corresponding to grade 2 or 3, but he is a person who helped us in diagnosing this case. We actually went through his article, we made the diagnosis in the HIV section, but just to satisfy the clinician, we wanted to do a IHC. And this, of course, has less mitosis and it has a positive immunolabeling, and so it belongs to grade 2. And the grade 3 is negative for immunolabeling, and it is what? Now, this is the classical picture, and actually our slide had these areas. Unfortunately, we couldn't capture those areas to your satisfaction, so we didn't do that. And this is the septae which you find and the lobular pattern of the tumor cells. So this is the one, you see, that is how he describes it. And when we went through the literature, we were able to make the diagnosis. A lobular pattern, diffuse proliferation mimicking an oligodendroglioma or a neurocytoma, rosettes corresponding to, and occasional ganglionic cells were observed. And then, of course, it had a biphasic pattern between pineocytoma and a pineoblastoma. So that clinched our diagnosis. And in fact, the ANPAT lab for whom we sent the IHC, they contacted me and they really thanked us for sharing such a rare tumor. They said in their lifetime they have seen the first case of intermediate differentiation of pineal parenchymal tumor. So this is a very, very rare type of a pineal parenchymal tumor. And the radiologists and pathologists have to be aware of this, because the treatment is different from other penial parenchymal tumors. Of course, I discussed it with my neurosurgeon. He said the patient is doing well after the surgery. And this is a take-home message for all of you. And these are all the references. The latest classification, which I have shown you, is the 2021, very latest. I'm sure some of you would have listened to the CNS symposium by Bhakti Santosh from Nimans. And do it. This is an article which was excellent to make the diagnosis of pineal gland tumor. So that is the main reason why I presented. So just to reiterate, you remember when I presented the tanicytic ependymoma, one of the points that I mentioned is site is important. If you find cervicothoracic region and if you do not find ependymal recess, and if the slide resembles a neurofibroma or a schwannoma, please think of a tanicytic ependymoma. In the same way, in the pineal gland, if you find a tumor of a divergent morphology, which I have already described, please think of a pineal parenchymal tumor of intermediate differentiation because it is intermediate in malignancy and you have to do a Ki-67 marker to know whether it is potentially malignant or not. Okay?
Thank you, Sita. Very, very well analyzed case for a PG level to all the people. Very nice presentation. And as you said, I first thought it is oligo. Then, as you mentioned, I was very happy. We are tracking towards. But when I read out that when you're reporting, you're presenting your description and the textbook matches. And one more question, only chromogranin on GFAP was done for these cases.
Yeah, I showed you the slides. GFAP was negative. GFAP was negative and chromogranin and synaptophysin both were positive. S100 was positive. So all the neurofilaments were positive. So what are the criteria for this neurofilament markers should be positive. Only then you can call it the parenchymal tumor of intermediate differentiation.
Very, very, very good presentation. Eye opener for we see so many cases, but this is a very rare one. Very hats off to you.
I've seen it for the first time. Even though we have worked in neuropathology in GH and we have seen so many cases in GH, I've never come across a pineal gland tumor there.
Yes. Yeah. We have heard about it, but we have not seen. But thanks for you bringing out for the entire pathology faculty. Very good, very good.
Question, ma'am. Here, the divergent differentiation which you were mentioning, no, ma'am.
Chandra, your voice is very, very feeble.
Ma'am, is it better now, ma'am?
No. Why? Where are you sitting?
I'm at home.
Closeted in the room? Let's come out. Yeah, otherwise you any other person want to contribute anything or comment? Sandhya is there? Sandhya has left? Okay.
Papillary pineocytoma may be many differential diagnosis for our ependymal tumors we come across. Let's Chita.
There is nothing called a papillary pineocytoma. It's only a papillary parenchymal tumor of pineal gland. See, the location is important here.
Madam? இல்ல இது சொல்றேன் நம்ம எப்படிமா அந்த மாதிரி சில டிடிக்குள்ள போதும் ஆமா location correct
so I don't think see it is of a primary it is of pineal gland origin. Yeah, Sandhya, you come back.
Yes ma'am, I'm right here. Yes ma'am.
You saw the case, any of your contribution or you have seen in the SRC anything like this?
Not recently ma'am, but definitely yes, we have seen cases like this.
Wow.
But one minute. Yes ma'am, what is the query ma'am?
Pardon?
Ma'am, what was the query? We have seen a couple of cases long back.
No, that's what I just wanted to know whether you.
Yeah. Yes, of course, ma'am. Of course, ma'am. Yes. We have. Yes, ma'am. Yes, ma'am.
It is a variant is saying.
Okay, Madam, I think you can proceed with that.
Yes, ma'am, that was a nice case. And can we go on to the next presentation, Dr. Bharati?
Yes, ma'am, I'm there. I start sharing my screen.
Yeah.
Ma'am, again, it's showing host disabled participants.
Yeah. Just give a second. Dr. Sarangan?
No, actually, he has enabled her. Bharati has been enabled to become the host, but I do not know. Can you send it to somebody else's mail and ask them to share it, Dr. Bharati?
Yes, ma'am. Right away. If anybody's mail is there, I have it in my mail.
Priya, can you just help her out?
You can send it to me. I'll share it then.
Priya Nigla.
Yes.
Yeah. I'm just sending her. Ma'am. Yes, ma'am. Sir. Ma'am, now I'm able to. I think.
Yeah, then you can start. You can start sharing.
Yeah,
Yeah,
can
ma'am.
start.
Yeah, we're able to see Bharati.
Yeah, opening.
Able to see my screen, ma'am?
Yeah. Your first slide.
Yeah, full screen, yes.
It's gone to the last. Yeah, good afternoon all. First of all, I would like to thank the organizers for giving this opportunity. So straight away going into the case, we received a specimen of gallbladder from a 52-year-old female with an acute abdominal pain. Exactly, she presented with the right upper quadrant pain. So they thought it as a cholelithiasis and we received the specimen. And this is a gross specimen. There is some papillary excrescences that was noted and our PGs were well able to identify this and given bits from this area. But extensive sampling was not done at that time. So this was later we went back to click the picture and took this after the bits have been given. And microscopically, this is a whole mount view of the same, which is showing some amount of nice polypoidal papillary projections apart from the normal mucosa, which is adjacent to that. So we went on to give more bits. And for our surprise, it was seen at multiple locations, this papillary sort of excrescences. And there is an abrupt change from there into the normal mucosa at a point. So this was like a cutoff where all the papillary excrescences started and it was measuring up to 1.8 centimeters altogether, the entire mucosal length, which was measured for the papillary structures. And at a high power view, you're able to see nice this papillary as well as some tubular arrangement of the glands, which was back to back. And the extensive sampling we just made to ensure that there is no invasion into the muscle. So fortunately, this had no muscular invasion, and the higher view of the glandular and tubular structures, which very much mimicking like the colonic adenoma. So that is what I just wanted to show this picture, because it was typically looking like a tubular or tubulovillous adenoma of the intestine. So this is still a higher view just to show the pseudo-stratified columnar epithelium with some amount of mucin-filled cells. So with that, the diagnosis of intracholecystic papillary neoplasm was made. If we remember older terminologies like biliary adenoma or papillary, tubulopapillary, intracystic tubulopapillary neoplasm, all this are nowadays obsolete. According to the ICD coding, the current recommended diagnosis that to be made is only intracholecystic papillary neoplasm. There are strict criteria to diagnose this entity. So it should be an exophytic or polypoidal neoplastic proliferation of the mucosa of the gallbladder, and strictly should be more than or equal to 1 centimeter in the total measurement. And it should ideally be non-invasive, sending a note to the pathologist to sample extensively to rule out a invasion. And it is distinct, it should be distinct from the adjacent mucosa, as I showed in my whole mount view, where it's abruptly turning into a papillary projection. So that is one of the mandatory criteria to diagnose this entity. And histologically, there are 4 interesting cell types, which I will be showing later. There are 4, which is biliary, gastric, intestinal, and oncocytic. So macroscopically, mostly these tumors are solitary, but about 30% of them can be multiple. And the commonest site being the fundus and the body of the gallbladder. And average size is between 1.5 to 2 centimeters, but ranges up to 7 centimeters. The larger the lesion, the more sample has to be made, definitely to rule out a invasive carcinoma. And this prominent exophytic or friable soft excrescences, if it is detached from its origin, that has to be sampled again to look for any secondary changes, which also may have a prognostic effect. And some are sessile and broad-based or pedunculated. Some pedunculated lesions may get detached from the lumen, which mimics like a gallstone or biliary sludge. That is the reason, unfortunately, radiologists will not be able to pick out this lesion. So it's very important, and sometimes it may be reported radiologically as only stones or some biliary sludge, and it turns out to be intracholecystic papillary neoplasm. And coming to the microscopy, as I mentioned, it can be of tubular pattern or papillary, when the designation tubular or papillary based on the percentage of the architecture that is appreciated microscopically, or it can be a mix of tubulo-papillary, which can range from 25 to 75%. And coming to the histological cell types, as I mentioned, it is the biliary, which is about 50%. It's the most common subtype. 50% of intracholecystic papillary neoplasm is of biliary type. And gastric, which again can be divided into pyloric and foveolar types. And intestinal, that is less than 10% of the cases only can be of intestinal type. And oncocytic, which is the rarest one. I show with the pictures, this is the papillary growth pattern, morphological 2 patterns. I said the papillary growth pattern where it is totally papillary excrescences are nicely seen and it is not invading the underlying mucosa. And this is the tubular pattern, growth pattern. Again, this is confined only to the mucosa. And coming to this is the biliary pattern where you see this biliary type of cells along with some amount of mucin. And this is the gastric pyloric type. And this is the gastric foveolar type. And this is the intestinal type. Why should we know about all these subtypes? So is there any prognostic significance? Yes. Biliary type, which I said most common being more than 50% of ICPN, is the one which has the propensity to develop into adenocarcinomas. More than 70% has been diagnosed to turn into malignancy. And gastric is the second common type with 36% of the cases. The foveolar again is have a high association with adenocarcinoma compared to the pyloric type, which is of lowest association among all the subtypes. It's only 5%. And coming to the intestinal type, which is ours, is less than 10%, and which very much resembles a colonic adenoma. As we see in this slide, it makes more of a colonic adenoma. And second most common that can turn into malignancy is this intestinal type, with the 60% of them showing features of malignancy. So why should we know all about these things? Extensive sampling is important for further prognostication of the patient. And oncocytic type, again, it is rarest. So very, very minimal case reports are available. It has a complex papillary architecture to it. So with that, if we want, we can, for academic purposes, we can go ahead and do an IHC marker, or for even prognostication to know the types, we can do a panel of markers of CK7 and 20. CK7 will be positive along with MUC1 in biliary type, and CK20, CDX2 will be positive in the intestinal types. So this can be helpful to subcategorize them. And genetic testing like TP53 mutation or KRAS or P16 strictly should be negative. Otherwise, you have to suspect a malignancy, and extensive sampling has to be done to know the exact invasion at what point of the muscularis it is getting invaded. And the close differential diagnosis of this entity would be the papillary hyperplasia. So how to differentiate them? When we have to report it as papillary hyperplasia, it should be a diffuse mucosal involvement, not a, as I showed in the picture, where there is a nice transition from the normal mucosa into a papillary area. So we will not be able to identify like that. It will be a complete diffuse hyperplasia of the mucosa, and there will not be any polypoidal projection also. It will be a flat lesion. And nodular hyperplasia of pseudopyloric glands again can be a high mimicker. And ectopic gastric tissue, but how to rule out this ectopic gastric tissue in subtypes like foveolar or pyloric? We have to appreciate the oxyntic and parietal cells along with the other two cells. So to call it as an ectopic gastric tissue. And flat dysplasia, as the name suggests, it's never a polypoidal projection. Histological features may be overlapping. If you appreciate the grade of the nucleus, everything may be very much similar to ICPM, but it is never a polypoidal projection, and it is a flat lesion, and it will never form a mass. So these are the take-home points that why we have to call it as an polycystic papillary neoplasm. So, ma'am, that's the end. Any questions?
Dr. Bharti, did you do the genetic testing here?
No, ma'am. No, ma'am. We didn't do, ma'am. We did extensive sampling. Almost we all embedded the papillary excrescent areas just to rule out an invasion. It was a very nice tumor which was confined only to the mucosa. Extensive search was made. It was never crossing the muscularism.
Okay. 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 What were the markers done here?
Ma'am, we didn't go for the marker, ma'am, but we can.
IHC markers.
IHC markers, ma'am. CK7 and 20 can be done, but we didn't do, ma'am. CK20 and CDX2 should be positive in the intestinal type.
So it was just with the histology?
Just with histology, ma'am.
Okay.
I just wanted to bring this to the notice because previously we were calling all this as adenoma and interchangeable terms like intracystic papillary tubulopapillary neoplasm. Those terms are obsolete nowadays, they say. According to ICT, we have to call it only as ICPN, intracholecystic papillary neoplasm. That's the recommended term.
Okay. Okay, Bharati. Thank you. Thank you so much for that nice.
It's occasionally we are seeing quite a few of these lesions, Dr. Valar, these papillary. Now we are recognizing them, and I think if we look at some of our archives, you may find a couple of cases like that.
You don't call them as adenomas,
that's what, ma'am. The term adenoma should not be used nowadays, they are telling.
But estrogen receptors detected in half of the adenomas to know that
is this equivalent to something like in endometrium EI and endometrium intraepithelial? Is it like that?
Yes, ma'am. It's an intraepithelial neoplasm like that only, papillary neoplasm, like how we call in breast and pancreas, very much similar only, intracystic papillary neoplasm.
Okay. Okay, thank you, Dr. Bharti.
Textbooks
Thank you, ma'am. Thank you.
Receptors to confirm the metaplastic change in this adenomas, that various types we mentioned.
Yes, ma'am. Yes, ma'am.
Estrogen receptors can be done, I think. Previous.
Yes, ma'am. I have to say it's more common in females and elderly folks. This is a very good study if it is conducted, ma'am. Yes, ma'am.
Yeah, but very nice presentation and good case, ma'am. Thank you.
Thank you all.
Thank you. Thank you, Dr. Bharti. This is the next presenter, Dr. Anandi. Dr. Anandi from Miyot Hospital.
Can you hear me?
Yeah, you can start your screen sharing.
Can you see my screen, ma'am?
Yeah. Yes, Dr. Anandi. Welcome.
All. Let's go to the case presentation. It's a 74-year female presented with complaints of white discharge, severe itching per vaginum, and also an ulcer in the vaginal region. PET scan showed bilateral inguinal lymph node metastasis, and outside slide we received diagnosed as squamous cell carcinoma. In a low power view, we saw a tumor seeming to arise from the basal layer of the epidermis and proliferating downwards, invading the underlying stroma. So in much higher power view, we saw a tumor which had this pleomorphic, loosely cohesive cells surrounding fibrovascular stroma, and it had this kind of hypochromatic nucleus at places. And at places, it was having this cells with prominent nucleoli and scattered melanin pigment laden cells in some of them. So we initially thought of a melanoma versus squamous cell carcinoma, and we went to do some IHC. HMB45 and melanine turned out to be negative in predominant population of the tumor, whereas scattered melanin cells were showing melanocytes were showing positivity. And pan-CK was strongly positive, and P63 and high molecular weight cytokeratin showed a peculiar pattern. There was thin fronds which are invading downwards. At this point, we gave a diagnosis of poorly differentiated carcinoma, and the surgeon went on to do a wide local excision. So we received a tumor which was showing again thin fronds of this epidermal cells. Tumor is present in the basal layer, and it seems to invade the underlying dermis. So this is another picture showing this kind of cells which are predominantly in the basal layer and seems to move little upwards from the basal layer. In the invasive component, we saw this tumor is arranged in nests and solid sheets, and it was compressing this normal squamous epithelium in between. So these cells had pale cytoplasm and a prominent nucleolus. So we thought to most first possible differential diagnosis we gave us invasive Paget's disease, and we also ruled out squamous cell carcinoma, which will be poorly differentiated type. And the other differential diagnosis considered are eccrine porocarcinoma, but it will have more basaloid cells with similar IHC profile to squamous cell carcinoma. And adenocarcinoma of mammary gland type, it must be more dermally centered, and it should not have this kind of extensive epidermal involvement. And least possibly sebaceous carcinoma also, which will be negative for CEA, but P63 will be positive. So we did further IHC workup. These cells were strongly positive for CK7, and it was even showing this pagetoid spread in the adjacent epidermis. And CK20 was negative. P63 showed only basal layer positivity, and CEA showed a strong positivity in these cells. So this is higher power view in P63. Only the normal basal layer of the epidermis, which was pushed downwards by these nests of pale cells, were taken positive. So the pale cells were negative. And this is high molecular weight cytokeratin, which was also negative in these nests of cells. So we did further workup to rule out any secondaries, like CDX2 was negative, and GCDFP15 and GATA3 showed strong positivity. We gave a diagnosis of primary vulvar invasive Paget's disease, or in otherwise called as invasive extramammary Paget's disease of the vulva. So coming to discussion, 90% of the cases are mammary type Paget's disease. Only 10% of cases are extramammary Paget's disease. Invasive vulvar Paget's disease represent only 1 to 2% of all vulvar carcinomas. In olden days, the Wilkinson's classification was used to classify this as type 1, type 2, and type 3. Currently, this is obsolete. So we have moved on to WHO classification of skin tumors. This tumor is mentioned both in skin tumors and female genital tract. So this in female genital tract, it will be mentioned as vulvar Paget's disease or extramammary Paget's disease. It's a rare adenocarcinoma, histopathologically characterized predominantly by intraepithelial growth of neoplastic cells, commonly seen in anogenital area in postmenopausal women. So currently it is of only two types, primary whether arising from the skin, and secondary it is to rule out urothelial or colorectal malignancy. So we have to use an approach to differentiate the secondaries. So CEA and CK7 will be positive in primary vulvar Paget's disease as seen in our case. And secondaries to intestinal malignancy, CK20 and CDX2 MUC2 will be positive. And secondary to urological malignancy, uroplatin and GATA3 will be positive. An interesting fact about this is the origin of Paget's disease in vulva. So it may be from the multipotent stem cells in the epidermal basal layer or in the infundibular stem cells of the hair follicle or apocrine glands, or the mammary-like glands located in the intralabial sulci. The current theory is All of them, both mammary and extramammary Paget's disease, arise from the Toker cells. So if there is no invasive component, as seen in our case, there was obvious invasive component. If there is no invasive component, there may be various mimics for this Paget's disease. I would like to highlight some of them. So one is pagetoid disc keratosis, where there will be pale appearing cells in the epidermis, and these are due to frictional irritation occurring in the skin, and there may be a erythematous rash. It may be due to the premature keratinization of the basal layer, which is moving upwards. And another one is pagetoid melanoma, which will also have a similar appearance. The third one is vulvar analog of stratified mucin producing intraepithelial lesion. It will have obvious mucin production in the epidermal layer. So another two differential is clear cell papulosis. It is an incidental finding due to glycogen accumulation. And is also an incidental finding. So if we have to approach them, we have to rule out clinical, we have to correlate with them clinically also. Pagetoid disc keratosis will have some clinical symptoms, whereas clear cell papulosis will not have clinical symptoms. Both will have high molecular weight cytokeratin positive, and EMA and low molecular weight cytokeratin will be negative. Toker cells and Paget's carcinoma, as we all know, it will be positive for EMA and a low molecular weight cytokeratin. Both will be positive for also for CK7, but Toker cells will be negative for HER2/neu, and Paget carcinoma cells will be positive, which may be positive for HER2/neu and strongly positive for CEA, as seen in our case. Moving on to genetic profile, HER2/neu expression is found in 70 to 100% case of mammary type Paget's disease. However, in extramammary Paget's disease, the frequency differs significantly. It may be negative. Mutations commonly occur in PI3K-AKT pathway. Another important point I would like to stress is role of P16 expression in vulvar extramammary Paget's disease. Many studies, including WHO female genital tract latest edition, mentions that P16 will be diffusely positive in extramammary Paget's disease. However, this positivity is not related to HPV infection, and this positivity is mainly seen in invasive extramammary Paget's disease rather than non-invasive extramammary Paget's disease. In our case, it showed strong P16 positivity and HER2/neu was negative. From the clinician's point of view, it is important to differentiate and find this diagnosis because there is high risk of margin positivity, whether it is an invasive type or a non-invasive type. The risk of recurrence is very high. Many studies mention that around 30 to 50% cases recur. And the prognosis is also very poor in invasive extramammary Paget's disease. Whereas in non-invasive, the prognosis does not differ much. It is usually has a good prognosis. So my take-home points are, even though it has wide range of histological mimics and differentials, it has to be diagnosed correctly because the high risk of margin positivity and risk of recurrence is there. And there is chance of misdiagnosis in small biopsy, especially many cases are being diagnosed as melanoma because of this pushing epithelial fronds, melanocytes in the dermis. And we need to differentiate primary from secondary as the treatment differs for the both. And strong clinical correlation is necessary for further confirmation. These are my references. Thank you. This is Sir James Paget. This disease was discovered in 1874. So I would like to dedicate this presentation to him. Any doubts? That's it, ma'am, for my presentation. Any questions? Am I audible, ma'am?
Yeah, you're audible, ma. You're audible.
Yes. Okay.
Yeah, that was a nice case. And any questions?
No questions. Very good presentation. She clarified all our doubts.
Thank you, ma'am. Thank you.
Very nice.
Can we go on to the next presentation, Dr. Asma from Rela?
Yes, good afternoon, ma'am. Am I audible?
Yeah, you're audible.
I'll share the screen. Anandi, you have to stop sharing the screen. Okay. Ma'am, is it visible?
Yeah, your screen is visible.
Okay, ma'am. So my case is a body fluid actually that we came across. So that patient was from Oman, 64-year-old male, and he was actually being worked up for a transplant. Query cryptogenic end-stage liver disease. He had refractory ascites. And while we were finding out history from the clinicians, somebody just mentioned that yes, in the body fluid, atypical cells were mentioned, but they were not sure what it was. And it was in Oman, but he did not have any pathology report with him. So here the tapping was done, and the ascitic fluid was hemorrhagic in nature, and smears were made. And the smears were cellular with many mononuclear cells which exhibited plasmacytoid morphology, abundant cytoplasm, eccentrically placed nucleus with atypical features in the nucleus with nuclear indentation, and some of the nuclei even showed prominent nucleoli. And few of the plasma cells were binucleate, trinucleate with occasional mitosis and apoptotic bodies in the fluid itself. CBC wise, we had received a blood sample for complete blood count. He had hemoglobin around 8 gram. However, the WBC and platelets were within normal limits, and the viral serology was also looked into during the workup, so that was non-reactive. We proceeded with we informed the clinician that it could be a hematological neoplasm, and we had asked them to proceed, raise a bill for flow cytometry. So the sample came for flow also. So here you can see there is a population, distinct population in the CD45 dim area. So these are our lymphocytes, which are CD45 bright. The next population is monocytes next to the lympho. So these two populations are CD45 bright. In comparison to that, I am saying that this is a CD45 dim atypical cells. So which were comprising around 36.17% of the total cells that we acquired. These cells were positive for CD19. However, CD20 was negative. And CD19 positive, 56 negative on flow. And in the next plot, the CD19 positive, 20 negative tumor cells exhibited CD38 positivity. So CD38 was kind of bright positive here. And and we also attempted cytoplasmic kappa and lambda. However, the cytoplasmic kappa lambda was equivocal. So I'm just trying to say that here I'm just depicting the plots of mature B lymphocytes. You can see CD45, 19 positive mature B lymphocytes, which are 20 positive, and they have worked very well. Kappa and lambda appearing polyclonal in the CD20 positive control B lymphocytes. However, the tumor cell did not show any expression of kappa or lambda. So it was given as equivocal in the body fluid sample. So I could not conclude it as a plasma cell neoplasm yet. So we simultaneously, my colleague Dr. Gauri had received the fluid in histopathology. So she had processed it for cell block, and in plasma, she had reported these atypical cells with plasmacytoid features. And when we discussed the case together, and we thought it could be a hematolymphoid neoplasm, still in our mind, the possibility of a plasma cell neoplasm was there. And we went ahead with IHC because cytoplasmic kappa lambda had not worked. So we cannot call it a plasma cell neoplasm. On IHC, CD138 membranous positivity, very beautifully, it had highlighted the tumor cells. The other markers, MUM1 we had done. So MUM1 was positive. We also proceeded with EMA. So EMA was positive. And CD30, we can see few cells have taken up CD30. Again, the tumor cells are negative for CD20. 56 was negative, similar to what was seen in flow cytometry findings. The Ki67 was unusually high. So we also went ahead with EBER in this case, which was negative. So we labeled the case as a plasmablastic lymphoma. However, we also suggested the clinical counterpart to go ahead with myeloma workup because that needs to be ruled out. So bone marrow aspirate was done, flow was done on the bone marrow aspirate, which showed normal trilineage hematopoiesis, no increase in plasma cell. There was no evidence of serum M protein, no evidence of raised calcium, any renal damage or bony lytic lesions. The PET-CT was performed, which showed some uptake in the ascitic fluid. So there was no other lesion anywhere else in the body for the patient. So just taking you through the features of plasmablastic lymphoma and why we concluded it as a plasmablastic lymphoma, even though the first possibility was that of a plasmaceal neoplasm. So plasmablastic lymphoma is an aggressive non-Hodgkin lymphoma with diffuse proliferation of large neoplastic cells which resembles plasmablast. They can have plasmacytoid morphology with very bizarre nuclear features. So how are they identified? They are usually mature marker negative, that is CD20, PAX5 negative, and are positive for the plasmacytic differentiation markers. Those are the CD38 and 138, which were positive in our case. MUM1 was positive. We do not have BLIMP1. So these tumors can also have variable expression of 4579 alpha, EMA and CD30 as per what is given in the WHO. That's why we went ahead with EMA and CD30. EMA was nicely positive, CD30 was positive in few of the tumor cells. Weak CD20, however, can be seen in 10% of the cases. So plasmablastic NHL, I already have highlighted that the viral serology was negative in this patient. And usually it is seen, it is highlighted because of the, it is presenting, the usual presentation is in retropositive individuals and the sites are oral cavity, digestive tract and skin. And there will be 60 to 75% of the cases will present with bone marrow involvement and B symptoms. However, in retro-negative patients, the patients who are viral serology negative, there is less frequent involvement of the bone marrow with less frequency of B symptoms also. So coming to the discussion part, HIV negative and non-transplanted cases in one of the study published in Blood Lymphatic Cancer, they had studied 62 patients, out of which in 55 immunosuppression, autoimmune diseases or chronic systemic inflammatory diseases, even though they were HIV negative, and even an age factor of over 60 years, which can lead to immunosenescence or an immunocompromised state, can be seen in plasmablastic lymphoma cases. So PBL is usually EBV positive. Again, this EBV positive correlates with the viral serology status of the patient. Usually the 75% of these patients are usually retropositive or they are in the immunosuppressed state post-transplant patients. And HHV8 is consistently absent in this patient. So the one point here is we can have other differential diagnosis that why it is not a large B-cell lymphoma with plasmablastic features. So that was the thing, first point, that it is negative for CD20 and the other B-cell markers that are CD79 alpha and PAX5. And when you get such such cases where large B cells with the expression of 20 has been concluded, but the morphological features of plasmablastic features are there, we can conclude such lymphomas as large B cell lymphoma, not otherwise specified. So I'm just concluding the case here because the differential diagnosis here was a large B-cell lymphoma with a plasmacytic differentiation, excluded because CD20 was negative upfront and it was not CD45 bright, it was a CD45 dim tumor, versus plasmablastic lymphoma versus a plasma cell myeloma transformation, which was again excluded by doing the plasma cell myeloma workup, which was negative in this patient. So when we get such cases, we are, because of the hypnotizing patterns, we may get misled and we may not be able to conclude the diagnosis. However, the guidelines are clear. We need to work up the patient in all ways possible with all the possible resources available. And we have to narrow down the diagnosis, even though the possibilities may be, more than one in such cases. Thank you.
That was an interesting presentation, Dr. Asma. And for discussion, please.
Yes.
It was a nice case, Dr. Asma. I just wanted to share, we too had a very similar case. It
Yes,
was
ma'am.
a positive patient who presented with a small intestinal mass. The clinical diagnosis was carcinoid, and they resected, they did an excision, they resected the bowel with the mass, and it turned out to be a plasmablastic lymphoma.
Yes, ma'am. Yes, ma'am. This case actually was highlighted mainly because of the retro-negative status of the patient and the unusual site. The first thing we thought was the plasma cell neoplasm. However, the myeloma workup came out negative. And then we went ahead with the IHC markers, which could favor the diagnosis of a plasmablastic lymphoma. That is how we proceeded.
Okay.
So IHC was done after the myeloma workup was completed. Additional IHC.
Oh, thank you, Dr.
Thank
Nice
you, ma'am.
case, nice discussion.
Thank you, Dr. Asma. Can we go on to the next case? It is Dr. Arun from Stanley. No.
Ma'am, good afternoon, ma'am. Ma'am, am I audible, ma'am?
Dr. Arun, you're audible. You can continue.
Yes, ma'am. Good afternoon to everyone. I'm just here to share one interesting autopsy finding, which is unveiling the truth and interesting autopsy case. And I'm here to thank the HOD of our department, Dr. Arunlata ma'am, and professor who reported this case, Dr. Nalli Sumitra ma'am. The case was a 22 years old male with history of fever brought dead to the hospital with only duration of 2 days, and their diagnosis was query tuberculosis, query malaria. The gross organs which were received were liver, lungs, kidney, heart, and spleen. Their autopsy findings: liver was intact with congested cut surface. Lungs were consolidated and were adherent to the chest wall with cut surface showing exudate admixed with blood. Kidneys were unremarkable. Heart was normal size with myocardium showing zone of hyperemia. Spleen was enlarged with thickened capsule and congested cut surface. So this was the gross appearance of the spleen. Spleen was enlarged and cut surface was showing, entire cut surface was showing brownish discoloration. And liver was also showing those brownish discoloration. Lungs again were congested. Kidneys, heart, everything was showing congested cut surface. So in microscopy, spleen at one foci, we were able to see this yellowish brown crystals which were surrounded by foreign body giant cell reaction. So we tried to identify the causes for this. We have most common cause they have given pulmonary hypertension, embolism, then sickle cell disease. All those were given as causes. So we went back to the history. It was a 22-year-old male, and the patient being a North Indian, we tried to evaluate at high power to look for any sickled appearance of red cells, and all the blood vessels were occluded with the sickled appearance of red cells, and not only in spleen, and these were also found in other organs. So this was nothing but a gamma antibody, which is nothing but siderotic nodules which are yellowish brown and spheroidal with deposits of iron and calcium, and that will be associated with a granulomatous inflammatory reaction, and they are usually 10 to 49 microns, and due to chronic episodes of vaso-occlusion and hemolysis occurring in the central arteriole of the white pulp, and can be found in 65% of patients. And in liver, again, we were able to see sinusoidal spaces were congested diffusely, and they were occluded with these sickled appearance of red blood cells. And it was also in every other organ, even in lungs, the interstitium showing, the interalveolar spaces showing congested blood vessels occluded with these cells, even in kidneys and also in heart. So all those organs which we have examined showing occlusion of blood vessels with the sickled appearance of red cells. So sickle cell anemia, how it presents, what is sickle cell and how it presents with death. So it is an autosomal recessive inheritance and can present either as heterozygous or homozygous forms, and we know it is due to a point mutation where glutamate is replaced by valine. So the clinical course, they will have multiple crisis or painful episodes, which is the hallmark of this disease, and that includes vaso-occlusive crisis, infarctive stroke, acute chest syndrome, aplastic crisis, hemolytic crisis, and also one more important thing is infections. So the trait patients, they will be mostly asymptomatic, and crisis can occur only if they are exposed to or if they are exposed to extreme hypoxic conditions. Factors that can precipitate these vaso-occlusive crises are cold weather, infection, dehydration, acidosis, alcohol intoxication with stress and pregnancy. So common causes of death they have done many studies in this. Most common cause of death in few studies they have mentioned as chronic organ failure, and in some studies they have mentioned infection being the most common cause of death. So manifestations usually in Indian population, they will be mild because of high HbF levels. So they will usually have late onset of presentation and they will be mostly asymptomatic and less frequency of all these crises. So most of them remain undiagnosed. Acute sequestration crisis is the most common disorder. Here in spleen is enlarged because of sequestration crisis due to sudden accumulation of large amounts of blood, which leads to severe anemia and shock and death. So death can be due to acute chest syndrome, sickle cell crisis, chronic organ damage, painful sequestration, splenic sequestration crisis. So what we are telling in most of the studies is the precipitation factor, that is they will present in 1 or 2 days and they can go for sudden cause of death, sudden death. So in this 1 or 2 days is the very crucial factor to save these patients. So patients who are diagnosed already with sickle cell disease and if they are presenting to the hospital with these precipitating factors like infections which manifest as fever or other things, we have to be very careful to diagnose and we should be able to save these patients who are already diagnosed. But most of those patients who are undiagnosed, if they are presenting suddenly, this infection can precipitate this sequestration crisis, sickle cell crisis, and can result in sudden death. And this being in our patients who have remained undiagnosed until this 22 years and they have presented with fever, so we diagnosed as sickle cell disease with vaso-occlusive crisis with infection being the precipitating factor in our case. Thank you, ma'am.
Thank you, Arun. That was a rare presentation in autopsy for discussion.
Very good presentation. Autopsy findings, as you mentioned, sickle cells, many of them would not have seen, I think, not as a regular autopsy finding.
Actually, one clue which we had in this case, which we thought was patient was being a North Indian, we tried to, actually in the initial screening of slides, we were not able to really identify them. But patient being a North Indian, because of these deposits, we were able to see the slides again under high power. So first we didn't really identify them.
Very good. Very good. Yeah, young patient also.
Yes, young patient, 22 years.
Very good, very good.
Thank you.
These are all more important. Actually, from autopsy, we learn a lot. That is why that was given as a main study for us as pathologists. You will learn a lot when you do more autopsies.
Yes, ma'am. True, true, as you said.
That is a traditional in those days when we were students. The number of cases you do, so many rare diseases, description, interactions with other departments, we will be able to coordinate and come to a diagnosis. I don't know, now they follow or not. Sandhya?
Ma'am, I think Madam is not.
Sandhya.
She might come back.
It was really wonderful, Dr. Arun. The observation was really good and it was a very...
Thank you, ma'am.
Thanks for the share. It was really good.
Ma'am, can we go on to the next case? Ma'am, from Vijaya Hospital.
Oh, that Sarah said her son is not well.
Okay, ma'am. Okay, okay. Then she's not able to do it.
They said sudden some bleeding nose and she was to take him to hospital.
Ma'am, this is from Chettinad Hospital.
Yes, ma'am. We are ready.
Yeah, please. You can start screen sharing.
Very good afternoon, ma'am.
senior
Welcome,
pathologists,
welcome.
suspected
Yeah.
seniors, friends and budding pathologists. Warm greetings from Chettinad Hospital and Research Institute. I'm just sharing. Are you able to see my screen?
Yeah, we are able to see your screen. Yeah. Dr. Femila.
Yes, ma'am. We
Okay.
thank the organizers for giving this opportunity. I am Dr. Femila, professor in Department of Pathology. Here we have two cases to be presented for the day. So the first case is, my slideshow is visible, ma'am?
Yeah, you can go on.
The first case is a 75-year-old male.
Go to the full screen mode.
It's full screen for me, ma'am.
Now actually, no, it is not seen. That is one portion shows something else and one part shows your PowerPoint.
I think your computer screen, your.
One second.
Share it again, no, if possible. Yeah,
Yeah,
now it's okay.
Now it's fine. Oh my.
Now is it visible, ma'am?
No, you've just started screen share. Yeah, you can continue. You can go on, Dr. Femila.
So our case was a 75-year-old male who presented with unilateral paratesticular swelling. We received a high archaeectomy specimen with an already cut open mass in the paratesticular region, which was measuring 7 into 6 into 2 centimeter. The outer surface was covered with fascia. On extending the cut, the tumor was yellow to gray white and focally tan colored. The surface was smooth. It was firm in consistency. The margins were pushing and not infiltrative. One second, I'm not able to move this slide. Okay, the margins were pushing and not infiltrative. The testis measured 5 into 3 into 2 centimeter and tunica was intact and smooth. Cut surface of the testis was unremarkable. String sign was positive. The testis and the spermatic cord were not adherent to the mass. Epididymis and spermatic cord were unremarkable. On a microscopic examination, the tumor showed a mixture of two components, adipose and the fibrous tissue components, which were blending with each other. The adipose tissue was mature and did not show any atypia. The fibrous tissue component showed plump spindle-shaped cells arranged in intersecting fascicles and scattered atypical giant cells, which showed abundant eosinophilic cytoplasm, multinucleation, and multilobation of the nuclei. These nuclei had coarse, clumped chromatin, prominent macronucleoli, and hemosiderin-laden macrophages were also found. The fibrous tissue component showed the lymphoid aggregates, lymphoplasmacytic infiltrate at a few foci. So no necrosis or lipoblast or ropey collagen or florid type giant cells were seen. Both epididymis and testes were free of tumor. So before proceeding with the immunohistochemistry, the differential diagnosis which came to our mind owing to the clinical, gross and the microscopic features were atypical spindle cell bar pleomorphic lipomatous tumor. Second one was atypical lipomatous tumor bar well-differentiated liposarcoma, that is ALT bar WDLS. Third was a fat-forming solitary fibrous tumor, SFT. So before going to the immunohistochemistry, let us see the points which favor. So this atypical spindle cell bar pleomorphic lipomatous tumor, it's a recently described entity. It is morphologically low-grade and clinically indolent adipocytic tumor, which is incorporated in the 5th edition of the WHO classification of soft tissue and bone tumors. So this atypical spindle cell pleomorphic lipomatous tumor, that is shortly called the ASPLT, originated by the merging of a atypical spindle cell lipomatous tumor and atypical pleomorphic tumor, lipomatous tumor. Earlier, atypical spindle cell lipomatous neoplasms were originally termed spindle cell liposarcoma. So spindle cell liposarcoma were then regarded as a variant of atypical lipomatous tumor bar well-differentiated liposarcoma. The interesting fact is in the 2002 and 2013 WHO classification of soft tissue and bone tumors, spindle cell liposarcoma was still considered as a spindle cell variant of ALT bar WDLS. And then with the molecular genetic advancements, clinical, histological, and molecular differences between some of the atypical spindle cell lipomatous neoplasms and ALT bar WDLS became clear. So it appeared that a particular subset of them did not seem into any of the existing diagnostic categories of the adipocytic tumors, just like our case. So in 2017, the term atypical spindle cell lipomatous tumor, ASLT, was proposed for the adipocytic tumors with spindle cell features. Also, the same year, 2017, APLT, atypical pleomorphic lipomatous tumor, was proposed for a group of neoplasms with a pleomorphic lipoma-like appearance, but with atypical morphological features. And then Creighton's et al. Demonstrated overlapping morphologic and genetic features between these two entities, suggesting that both tumors belong to the same morphologic spectrum named ASPLT, atypical spindle cell bar pleomorphic lipomatous tumor. So these tumors are very interesting and they occur mainly in the middle-aged adults with a peak incidence in the 6th decade of life. There is a slight male predominance. This tumor appears as a persistent or enlarging soft tissue nodule or the swelling. It arises in the subcutaneous fat and to a lesser extent in the subfacial somatic soft tissues. There is a predilection for the limbs and the limb girdles. On gross examination, ASPLTs are nodular or multinodular lesions that are at least partly not encapsulated. The lesions have ill-defined tumor margins and they can grow infiltratively in the surrounding tissue. The tumor size varies ranging from 0.5 to 28 centimeter. The variable constituents in ASPLTs are atypical spindle cells, adipocytes, lipoblasts, pleomorphic or multinucleated cells, and extracellular matrix. The adipocytic component consists of mature appearing adipocytes. Patchy and mild to moderate atypia of adipocytes can be observed. Lipoblasts are present in almost half of the cases and range from small univacculated or bivacculated cells to larger multivacculated cells. Bizarre hyperchromatic and sometimes pleomorphic multinucleated cells are often scattered within the spindle cell or the adipocytic components. Areas with a spindle cell or pleomorphic lipoma-like appearance are described. Presence of ropey collagen is uncommon in ASPLT. So likewise, we also did not observe any ropey collagen in our case. Mitotic figures are scarce and necrosis is always absent. A rare finding is heterologous or the metaplastic differentiation with presence of smooth muscle, cartilaginous, and osseous elements. The neoplastic spindle cells and adipocytes show variable expression of CD34, S100, and desmin. The majority of cases show loss of nuclear RB expression, retinoblastoma expression, weak and focal expression of MDM2, that is murin double minute gene, or CDK4 can be seen, but the combination of MDM2 and CDK4 expression is not compatible with the diagnosis of ASPLT, whereas this favors the diagnosis of atypical lipomatous tumor bar well-differentiated liposarcoma, and it is even found in dedifferentiated liposarcoma. So the molecular studies, which include FISH and MLPA, that is multiplex ligation dependent probe amplification, they have shown deletions or losses in the 13q14, including deletions of the tumor suppressor gene RB1 and a consistent absence of MDM2 bar CDK4 gene amplification. So most patients have an excellent prognosis if completely excised. So sometimes recurrence is common. Unlike the classical atypical ALT bar WDS and the dedifferentiated liposarcoma, the risk for dedifferentiation and metastasis is minimal to almost non-existent in this entity. So we have always been heard of paratesticular liposarcoma in many, we have read it so, but this is a new entity. So we thought we have to discuss about this case. Now I'll go on to the second DD. So this case highlights the importance of distinguishing ASPLT from the ALT bar WDLS and dedifferentiated liposarcoma in order to avoid aggressive surgical resection. So the next DD was atypical lipomatous tumor bar well-differentiated liposarcoma, because prognosis-wise we have to differentiate these two, otherwise the patient will be in trouble. So this is affects the adults with the same age range as the ASPLTs, and also the broad anatomic distribution with predilection for the extremities is also same, just like ASPLTs. The lesions range from very small to very large in size. Grossly, they are well circumscribed lesions, and they can have irregular borders and infiltrative growth also, similar to the ASPLTs. They have no metastatic potential, but dedifferentiation to a dedifferentiated liposarcoma occurs in up to 10% of the ALT bar WDLS. And the recurrence is common. ALT bar WDLS may be morphologically indistinguishable from a fat-rich or a spindle cell poor variant of ASPLT. Compared to the ASPLTs, pleomorphic lipoblast are rather rare in ALT bar WDLS. Unlike the ASPLTs, ALT bar WDLS are characterized by supernumerary ring chromosomes or giant marker chromosomes with amplification of the MDM2 and CDK4 genes, which are detectable with the CGH, array comparative genomic hybridization, FISH or MLPA techniques. And nuclear expression of the same markers can be detected immunohistochemically, though we do not have that provision, whereas there is no overexpression for these markers in ASPLTs. And another marker for differentiation is the RB gene, which is absent. The deletion of RB gene is absent in ASPLTs, whereas it is preserved and it is expressed in ALT bar WDLS. Fat-forming solitary fibrous tumor was a remote DD for us, and it is a recognized rare morphologic variant of SFT. It usually affects the middle-aged adults. They mostly occur in the deep soft tissues of the lower extremities and the retroperitoneum. Most fat-forming SFTs have an indolent clinical course. However, the biological behavior is highly unpredictable in case of SFTs. They are morphologically similar to the conventional solitary fibrous tumors, except for the presence of variably prominent adipocytic component. They are composed of bland spindle cells with a patternless architecture embedded in a variably collagenized stroma and admixed with a variable number of mature adipocytes. In contrast with the ASPLTs, solitary fibrous tumors typically contain many branching staghorn-like blood vessels, which only clinches the diagnosis. So there are no lipoblasts in SFTs, and the spindle cells and adipocytes show no cytonuclear atypia. So that is the differentiating feature between the atypical lipomatous tumor and the fat-forming solitary fibrous tumor. Nuclear STAT6 positivity, CD34, CD99, and BCL2 positivity, they are all characteristic features of SFTs. Unlike ASPLTs, SFTs are not characterized by deletion of RB1 gene and corresponding nuclear loss of expression for RB. So now we proceed to the immunohistochemistry with all these features in mind. So our case was a smooth muscle actin positive in the spindle cells, and CD34 was positive in some of the spindle cells and was negative in the giant cells. S100 was negative in the spindle cells and the giant cells, but it was positive in the nuclei of some of the adipocytes, just considered normal. And the Ki67 was positive in 5% of the tumor cells. Hence, our final diagnosis was atypical spindle cell bar pleomorphic lipomatous tumor. So, however, we advised the ancillary testing for loss of MDM2 or CDK4 amplification to rule out the well-differentiated liposarcoma and the propensity for the recurrence. Any questions, or shall I move on to the second case?
You said the SFT was your differential diagnosis, no? SFT.
Yes, ma'am.
How did you differentiate that one?
Ma'am, I did the CD34 for that, ma'am. But it was negative.
Yeah. Right.
It is supposed to be positive, so
Yeah.
but it was negative.
But histologically also not very confirmative of SFT, isn't it?
Yes, ma'am. Histologically also, this was more appealing than the SFT.
More of that, as you said, MDM2 is more important.
More important. Yes, ma'am.
Yeah, points to be taken in the take-home message.
Madam,
Thank you.
it is because paratesticular, we had a
third DD of SFT. Otherwise, we wouldn't have thought of SFT in this morphology.
No, many cases now SFT play a role. Many tumors, the pattern is so significant nowadays. We always gives a differential diagnosis and we want to exclude. Though once it was very rare and now every site it can come. So many tumors present with this feature. So what she said is right only, but as she has mentioned, she has classified it in a proper way to the slender, that is spindle cell pleomorphic spindle cell tumor to differentiate from a well-differentiated type. Very well presented. Good, Vijayasree.
Thank you, ma'am. We shall now move on to the next case if no more queries are there.
Yeah, Dr. Famila, please move on.
Case number 2. It was a 65-year-old female who presented with a mass involving the uterus and the parametrium. We received a specimen of hysterectomy with bilateral salpingo-oophorectomy. On gross examination, a large nodular mass was seen arising from the posterior aspect of the uterus involving the cervix and the right adnexa. It was measuring 21 by 17 by 10 centimeter. Right ovary had been completely replaced by the tumor. On cut sections, 70% of the nodular mass was solid, 30% was cystic. Hemorrhagic and necrotic areas were also seen in a few foci. Hemorrhagic serous fluid drained out of the cystic areas in the tumor. The solid areas were fleshy, gray-white, firm, with focal gray-brown areas. We had also received biopsies from the tumor deposits in the pouch of Douglas, mesentery, and omentum. On microscopic examination, a well-circumscribed unencapsulated tumor was seen arising from the myometrial plane of the uterus, infiltrating the cervix, parametrium, and replacing the right ovary. The tumor infiltration was more than 50% of the myometrium and had replaced the posterior lip of the uterus, breaching the serosa. The tumor cells showed varied morphology at various sites. In majority of the foci, the tumor cells were arranged in sheets, nests, trabeculae. In these foci, the tumor cells were polygonal to round, had abundant clear cytoplasm, markedly pleomorphic nuclei, scattered cells with bizarre nuclei, hyperchromatic to vesicular nuclei, nuclear lobation, coarse chromatin in cells with hyperchromatic nuclei, prominent 1 to 5 macronucleoli, 6 to 8 mitotic figures per 10 hyperfields. Geographic areas of tumor necrosis were also seen. Whereas in some of the foci, the tumor cells showed smooth muscle morphology and were arranged in whirling and intersecting fascicles, had focal cystic degeneration, mild chronic inflammation, scattered atypical cells, and extensive areas of hyalinization. These spindle-shaped cells are seen merging with the tumor cells with clear cell morphology. At a few foci, the tumor showed endometrial stromal sarcoma-like morphology. Biopsies from the pouch of Douglas, mesentery, omentum showed infiltration by the tumor. So with all these features in mind and 65-year-old post-menopausal lady, the first thing which came to our mind was carcinosarcoma, that is malignant mixed Mullerian tumor. Of course, the gross presentation was slightly out of focus because they usually present as in utero polypoidal lesions. So the carcinosarcoma, just like the first case, this case also first we'll discuss the DDs and then we'll go to the IHC so that it concludes the final diagnosis. So carcinosarcoma is a biphasic malignant tumor with high-grade epithelial and sarcomatous components. Sarcomatous component is derived from the carcinomatous component as a result of metaplasia or transdifferentiation, that is epithelial to mesenchymal transition. It's a rare aggressive neoplasm which occurs in postmenopausal women, most frequently in the uterine corpus. Almost all are sporadic, whereas tamoxifen-used pelvic radiation therapy have been associated with an increased incidence. Other predisposing factors include chronic estrogen exposure, nulliparity, diabetes, and obesity. Grossly, they are polypoidal lesions, fleshy, bulky, and friable. Hemorrhage and necrosis are common. They may fill the uterine cavity and protrude through the cervical os. Extensive myoinvasion occurs and often extends beyond the uterus. The carcinomatous and sarcomatous components are juxtaposed on microscopic examination. The carcinomatous elements often include high-grade endometrioid or serous carcinoma, frequently which are admixed. More uncommonly, clear cell carcinoma also can be encountered. So that is how we suspected this case to be like that. Other components that can be rarely found are squamous, mucinous, and neuroendocrine. Sarcomatous elements are often spindled and pleomorphic. 50% contain heterologous elements, most commonly rhabdomyosarcoma and chondrosarcoma. Osteosarcomatous, liposarcomatous, and angiosarcomatous differentiation are less common. So immunohistochemistry is generally not necessary to establish the diagnosis like we do historically like this only, but can be useful to demonstrate the heterologous differentiation. So then next DD was epithelial leiomyosarcoma. Leiomyosarcoma is a rare tumor which is derived from the smooth muscle, and it is the most common uterine sarcoma. It's a rare de novo tumor. 3 types are present: spindle or conventional type. Second is the epithelial, and third is the myxoid type. It presents with a triad of histological features, that is severe atypia, increased mitosis, and tumor cell necrosis. Poor prognosis and limited therapeutic options only are available, and it peaks at the ages of 40 to 69 years. It arises de novo or in very rare cases from a pre-existing leiomyoma, and symptoms include abnormal vaginal bleeding and those related to a pelvic mass. Bulky, fleshy tumor invading into myometrial wall or polypoid tumor projecting into the lumen. Both ways it can present, often hemorrhagic or necrotic. Grossly, it appears invasive or infiltrative. It's very large with a mean diameter of 10 centimeter. Epithelial leiomyosarcoma is diagnosed based on the presence of moderate to severe cytologic atypia or tumor cell necrosis, or more than or equal to 4 mitosis per 10 hyperfills, which is slightly lesser than the conventional type. So round or polygonal cells with eosinophilic or clear cytoplasm. Tumor cells are arranged in sheets, nests, or cards. So with this in mind, we proceeded with the immunohistochemistry for this case, and the tumor cells in our case were positive for vimentin, desmin, but negative for pan-CK. We did CT10 also because we had the small oval cells which mimicked the endometrial stromal sarcoma differentiation, and CT10 was absolutely negative. And we also did HMB45 in the clear cell areas to rule out the constituent picoma, sugar tumor. So, but finally, HMB45 was also positive. So, keeping these in mind, vimentin and desmin only positive, pan-CK negative, CD10 negative, HMB45 negative. So, the final diagnosis was epithelial leiomyosarcoma, uterine corpus, infiltrating the uterine cervix, pouch of Douglas, mesentery, omentum, and replacing the right ovary.
Dr. Balar?
Yes, ma'am.
This is Dr. Vijayashri. Can I add a word in this?
Yes, ma'am. Please continue.
It was a very beautiful presentation by Dr. Famila. This case, when I don't know why they sent for frozen to us initially, because they weren't sure whether it's an ovarian tumor or a uterine tumor. So they sent a frozen, and in frozen, what we reported that was, we said it's a poorly differentiated carcinoma. When they said, no, it could be uterus, then we sent, because they only sent small fragments initially. Then we said probably it could be a carcinosarcoma, malignant Mullerian tumor. We couldn't even get the spindle cell area at all. Only when we got the entire specimen, we took about 20 sections to see the leiomyosarcoma area. It was merging with all the other de-differentiated areas. Only then we could think the possibility of leiomyosarcoma itself. Till then, we were not very sure. We thought either it is an ovarian tumor or it's a malignant mixed Mullerian tumor of the uterus. But when we got this particular area in the section where the smooth muscle component was adjacent to the tumor area with other cells, that is the when we had the doubt that it is okay, it's a leiomyosarcoma, nothing more than that. Then we went ahead and did all the IHC markers. It was such a difficult case, but turned out to be a very simple case actually.
Yeah, that was a very nice presentation, Dr. Famila, and thank you, Vijayashri ma'am. And I think Dr. Papati ma'am is a little busy today. She's not able to present. And so that comes up to the conclusion of the 29th City Pathology Meet. Dr. Chandra madam, can you?
Yeah. Yes, Valar. Am I audible?
Yeah, you're audible. You're audible, please.
Okay. So a nice array of cases as usual. So I really have to thank the presenters and the team from each and every medical college which has contributed the case. And of course, Dr. Valarmati for having organized this beautiful event. So anything else you can wrap up the session, or any other comments are there? You can.
Madam, are you there?
Yeah, I'm there. Can you hear me?
Yeah, ma'am.
Yeah.
Yeah. It was really wonderful having a mixed cases, like we had hematology and pediatrics and neurology, all cases. It was really good. The enthusiasm is stirring up, and this is the first session for this year, right?
Yeah, ma'am. Yeah, we had 2 more cases from Papati madam, but she was a
Yeah,
little
yeah.
busy
No
today. She's
problem.
not able to make it
Next time
today.
we can
Next
have.
time she'll present.
Yeah. So that was really wonderful. The spirit keeps going, and let us hope that we meet next time. Let us see whether we can meet up. The
Person
cases
and case.
will coming up.
Yeah.
Next city pathology meet will be in April.
Zoom meeting is
April, yeah.
wonderful today.
Zoom meetings.
Because no, why I'm saying, Valat,
Yes, ma'am.
many
Yes, it's
people may
convenient
not
for
be
everybody to log in from their own
many
place.
people may not be able to come in person, very far off places,
Yes,
time,
ma'am.
distance, their duties and classes, because we keep on all working days also, no? So it is not possible for
Yes, ma'am.
everybody. But now
So we
after
will continue with Zoom itself,
lunchtime,
ma'am. So we'll continue with Zoom.
I don't mind, because practicality is one thing we have to accept it. Because previously also, every college will have so much of trouble in arranging, and people have to travel. All that nuisance is
Okay,
not
maybe
there.
the annual thing we will have at least once in a year.
Like that we were
Once in a year, maybe.
Bigger session, something little different form of our meet we can do it.
Yeah.
Yes.
See, I think, I think Madam is right. We can continue the Zoom meeting, and occasionally we can have offline meeting, something to keep it.
Maybe like once in a year, ma'am.
Yeah, that would be nice, because that way we can assure that at least that one meeting, we can assure that everybody would like to come and meet.
Yeah. Yes, ma'am.
Anyway, and all important rare cases are being so far presented.
Yes.
You can put a booklet also.
Yes,
I feel that in the 1 year session, no, Valar?
Yes, ma'am.
We have to give the speakers the write-up and then in short form, and we can give it to the PGs or assistants. You can keep it in the department also. Like
Yes,
Ackerman used to have his record of his cases. So he used to go back and see whatever new case comes. It will be a reference for him. Though we may not be on par with Ackerman, at least we'll try to follow his principles.
Yes, ma'am.
That's true.
Very good, very good. And places like Ramachandra and Chettinad and government medical colleges, MMC, premier institutions, we have to follow this. I feel it's my wish. I don't know about others.
Okay, ma'am. Thank you, ma'am.
Thank you so much.
Thank you for your inputs, ma'am. Thank you very, very, ma'am, for your.
Bye.
Thank you.
And thank you.
Bye, ma'am.
Thank you, ma'am. Thank you. So we'll wind up the session. Thank you, Vijayashri, ma'am, and Dr. Familia for those cases.
Thank you so much, ma'am.
Thank you.
Thank you.
Thank you all. Sorry for that. Sorry for that. Yes, my dear.